Hello, welcome back to Unraveled, Understanding Complex Illness. I am Dr. Eileen Ruhoy, and I am with...
David Kaufman. Nice to have you back.
People,
Nice to be back.
People are just going to get tired of us introducing ourselves. So this is episode 16 or 17.
I think
anyway,
16
it's the next episode, and I'll count them up next time when we post this. But we actually, our Patreon page has been very active, right? So we're getting a lot of great comments, a lot of really good questions, and we try to answer on the Patreon page, and I think we do a decent job, but it's almost become a job of itself. And so we decided that we would take some of the episodes and actually address the questions because they're really good questions and we want them to keep coming in.
Right.
And so it also helps us to know where we sort of leave holes in our conversations that we don't know, the topics that we don't fully cover, that there are still questions left over that you guys have been asking. So that's been great. And we want to take a couple of episodes to answer them.
Yeah, the questions are great. There's one person who wrote in, I think, about 9 different questions, and I looked at this, I started to answer, said, wait a minute, there's no way I can do this on a keyboard. We have to talk about it. So that was the motivation or stimulus to decide to do it this way. And I have a personal interest in it in the sense that when I go to lectures or go to talks, I have about 1,000 questions, and I never really get to ask them. And I think they're such a crucial part of learning in the whole process. So
I completely agree. And it's great that these are, I think I'm assuming that some of these questions are coming from patients or from loved ones of patients, right? So they have a real, like they deserve to know, basically. So obviously our goal with this podcast is to educate and deliver information, and we want to be sure that we're comprehensive and thorough and that everyone is getting what they want out of it.
Right.
And that has been a learning experience for us because we've never done this before.
Exactly. One other disclaimer. Just because we're going to answer questions doesn't mean we actually know all the answers.
That's right. And exactly. We don't, and this is what we believe, and this is what we see, this is what we do, this is what we guide patients and advise patients on. But, over time, if you ask me the same question 6 months from now, I might have a different answer.
Oh, that is 10,000% true.
Right.
I mean, in the space of 3 months, I can change my approach or my understanding or a treatment or try a new intervention, and then it becomes a sort of a standard of care in my practice 3 months later. So
no, and we do very regularly. I do want to just tell you about my experience recently going back to New York to Mount Sinai South Nassau, the Chiari EDS Center, where we send a lot of our patients for CCI intervention.
Right.
And I had the chance to actually talk with them post-operatively. I did sort of the rounds, as they say. I used to do rounds in the hospital all the time. It's been many years, but it was fun to do. And I was so motivated and so moved by what happens to patients post-operatively in terms of their improvement of symptoms. And as we often talk, and this is sort of, I'm bringing this up because it leads into one of the questions about CCI. But when a patient is a surgical candidate and truly has CCI and does well on the invasive cervical traction, which we use as a screening tool now to decide who would benefit from surgery and who would not. And again, that's not black and white. It's more like who would likely benefit and who would likely not benefit. But when they prove to be a surgical candidate and they prove that they will likely benefit, and then they get the surgery and they do benefit, it brings me to tears. I mean, I actually cried with a couple of patients because some were truly bedbound and are no longer bedbound.
Yeah, Dr. Bolognese sends me these pictures of my patients.
Yes.
Either they're stills or videos, ICT or day one post-op, and I am crying. I mean, tears, because these are patients who have been in bed for 5 years and not talking, and all of a sudden they're standing and answering his questions.
I know, it's amazing. Yeah. And they're walking the hospital floors.
It's amazing.
I know. So I think that takes us to one of the questions, which is about the very severe bedbound patient, which we get a lot of.
Right.
Fortunately, for the advent of telemedicine, we're actually able to help these patients as best as we can. So the question is really about, so what is your approach? So you get a new patient who's a bedbound patient and it has been bedbound for a couple of years. So, I mean, it's a very long question with lots of little questions in it. But so what is our approach? What do you do with a new bedbound patient?
So I think this is going to require a separate episode. I think we should talk about
and maybe
it for
this
a
will
few
be this
minutes.
episode.
Well, okay, maybe we'll see what happens, okay? And maybe it should be because all of a sudden I'm flooded with these patients, and I don't know how that's happening. So a couple of sort of preliminary comments. The first is, as you said, telemedicine lets it happen. But, frankly, when you do it or I do it, we're going out on a big limb here. from a medical point of view and a legal point of view and a regulatory point of view. I mean, I've sort of come to terms with that or made my peace with it. It's what I'm going to do. I'm a doctor. I've done this long enough that I'm just going to do it. But I recognize that for most physicians, they just simply won't take the chance. They won't do it. That said, in my experience, and I'm sure in yours, we can do a lot. I would take it a step further. In the telemedicine, in the bedbound patient, actually all of the time, it's not, I don't even get to talk to the patient. I'm talking to their partner, their husband, their wife, their mother, their father, whoever it is giving me all the history. So it's telemedicine once removed, it's patient second removed. So it's a little bit bizarre, but it works. And if what I've found in the patients I've worked with is that the person I'm interacting with is incredibly concerned and compassionate and caregiving, so I get a good history and we really can make progress. But it's not easy.
No, it's not.
It depends on where the patient is. I mean, I've had patients in Europe where it can be really difficult or easier, depending on, how we're proceeding. But it can be done, I think a lot of it is a index of suspicion, as I've said many times in these talks with you. And I will confess at this point, I think I've said this in some of the other episodes, if I get a 100% bedbound patient, as far as I'm concerned, my first job is to rule out CCI, because I think that's what's going on. And unfortunately or fortunately, that's been the case every single time.
I completely agree. And it seems like they are almost always proven to be surgical candidates when they're able to get to the hospital, which is, of course, is a big obstacle. And I agree. And I think that, it is hard, of course, legally speaking, when you get a new patient who's a bedbound patient and obviously can't travel to see you and you can't travel to see them, then you don't really get the benefit of doing a full physical examination, which, of course, is not ideal. And, I often worry, am I missing something? And there are other obstacles just in terms of even, if you need to get labs ordered, how that gets done. I mean, some patients already have sort of set up mobile nursing that comes to their home, like home care. So sometimes we can get phlebotomy done and get some labs done at least so that you can look for certain markers just to make sure, to at least start to make sure that you're not missing an alternative diagnosis, or at least something that's treatable. It doesn't mean that CCI doesn't exist, because it most likely exists in these patients. But, you want to find other things that you could potentially treat. And so that can be really hard to do in a remote kind of, patient-doctor relationship. So I do think medical legally it's very, it's burdensome. But, the reward when you actually do help them in the end is so great that it's worth all the time and the risk, I think, that we take for patients.
Right.
And it's nice to have that they have caregivers around them, because we can, as you said, we get a lot of our questions answered, because as we talk about, history is so crucial. And fortunately, you could get a lot of that history just because they usually have some really good support systems within their home to help care for them. But I do agree that CCI is the most likely diagnosis for these patients, especially if they come with a history of the septat kind of patient, right? If they have that kind of history and it's progressed over the years and now they can only do minimal, if any, activity, then clearly CCI needs to be ruled out. Do you have them do the home traction trial at that point, or do you just go right to?
No, I definitely do the traction.
Yeah.
Not me myself, obviously.
No.
I usually try to teach the person I'm talking to, the caregiver, how to do it. And in some cases, been able to get a physical therapist to come to the house.
Right.
I'm nervous jumping to aggressive traction unless I've had somebody with the knowledge do an exam, especially since I'm not there to do it.
Right.
But I've also found that a little bit of traction tells you an awful lot.
It definitely does.
Unlike some other patients where we do over-the-door traction up to 20 pounds, with these patients, just 60, 90 seconds of manual traction, you have your answer.
I completely agree. It could be that easy. And I often will guide one of their caregivers to just sort of where to place the fingers and how to extend the skull off the cervical spine. I often talk about how positioning is really important, because if you're in the wrong position, you won't get the benefit. In fact, they could
make it worse.
Yeah, right, exactly. They could feel worse, and then they'll think that this is not their diagnosis.
Right.
I might have said this in another episode, but I often will explain that, EDS patients in general, when we were growing up, and at least us girls, we used to put books on our head and walk like models. That was going to like correct our posture, and that's what we were raised to think was perfect posture kind of thing. But EDS patients don't have that kind of posture. In fact, usually their chin has to be slightly flexed down a little bit. For a more natural kind of alignment for them, for the traction to show benefit.
Right.
And so sometimes, when patients are able to sit up, so this is not necessarily the bedbound patient, but at least the homebound patient, when they're able to sit up and do the home traction, they'll tell me that it hurts, and it's usually because they're sitting, too high and too straight. And so I have to sometimes correct their posture and have them redo it, and there will be a different response. So similarly with bedbound patients, I try to explain to the caregiver sort of the position that I hope to have, and I've been known to like draw pictures on paper and show on the camera on the video. So but traction, you're right, just a minute of traction in the right position can actually show a great benefit.
Right.
I've often been asked, if you have CCI and you don't address it, can it progress? The answer is yes, it will. Certainly as you get older, it will. As you get sicker, it will. And are there conservative measures if you're on the more mild end of CCI? And that's an important point that I often get asked, and I'm sure you do too. Does CCI always mean surgery? Right. So I know we started this conversation about bedbound patients, but just to sort of go to the non-bedbound patient for a second, if you have, CCI, I think at this point in my trajectory of working with patients with chronic and complex illness, I believe CCI exists in the vast majority to some extent. And whether or not they're a surgical candidate, and whether or not it's pathologic, is a whole other story, right? So how much it's contributing to the symptoms, that's a whole question to answer of its own. But does it exist on some level? I believe yes is the answer. And if not addressed and not managed, I think it will progress. And there are conservative measures. You don't always need surgery if it is pathologic at all, if it's contributing to symptoms. I think it doesn't necessarily mean at that point you need surgery. And that's why we do the screening tool of invasive cervical traction, and we've talked about that certainly in the past. But I do think that it exists. And when you learn, when you see enough patients and you understand the septad diagnoses and you understand sort of their body physiology and the body anatomy, sometimes I say, how can it not exist, right? So, and then with their symptoms, it so localizes to that particular part of the anatomy that I think that we can find instability when we look for it. But it doesn't always mean that it's like the major component of why they're
right. Well,
coming
like
to see
so
the
much
doctor.
what we do, it's a spectrum, another
Right.
spectrum illness. I think one of the questions in there is, does all CCI mean brainstem compression? I think the term that the questioner asked was,
Right.
does it mean cranial settling?
Pull out my papers again.
And the answer is no.
Right.
I mean, I agree
No.
with you. You can have CCI,
Right.
instability, without full-blown brainstem compression, full-blown bedboundness. And I think, as I think we've mentioned in some other episodes, I've come to believe one of the biggest challenges of my job and biggest responsibilities is to precisely find those patients before they have settling and before they have compression, because that's where they're going to end up unless we can fix the other pieces of the septad and figure out some ways to strengthen their connective tissue. So in summary, by no means does all CCI mean surgery,
Right.
but it needs to be considered in all of these patients.
Absolutely. Because if it exists, it needs to be at least acknowledged.
Right.
Because then you can start conservative measures. But then obviously once it's progressed, and then usually, like we said, the bedbound patients most commonly have CCI that needs to be surgically intervened, because at that point it's a true anatomic diagnosis. Exactly. And as we always say, all of the medications in the world are not going to correct the anatomy.
Right.
And even some of the manual maneuvers can actually give some relief for a brief period of time, but it's not going to be sustained. And to definitively correct it, you really do need surgical intervention. And at this point in our medical history, fusion is really the only surgical intervention that's being offered for cranial cervical instability. And I do think that it's becoming a little bit more accepted amongst the surgeons of, I don't want to say the world, of pockets of this country, but clearly we need many more surgeons in this field and in this space for sure. And the obstacle, of course, is that now, because there are so few neurosurgeons, the bedbound patient and their family will ask, well, how do I get there, right? And I'm asked that all the time. Like travel is such a huge obstacle for these patients. I mean, it breaks my heart, frankly.
Yeah.
And, I've written so many letters to insurance companies explaining why they have to go to New York or to some other state because there are no neurosurgeons in their local area that can help them. So they need air ambulances. They cannot fly commercial. It's insane.
It's unbelievable. I have a patient who just Dr. Bologna has just operated on her, had ICT, and the next day had surgery.
Mm-hmm.
That's how significant it was. So she's 100% bedbound, hopefully was 100% bedbound in Washington, Seattle. And we tried to get an air ambulance okayed. I actually had the patient's husband had a local neurosurgeon write the letter, the whole thing. Insurance said, no, you don't need an ambulance. This poor family had to get an RV, a van, fit it out with a bed, and spend a week driving across the country to get there, which itself is traumatic because the roads have bumps. It's crazy.
No, that's exactly right. I mean, road travel is hard on them.
It's just crazy.
You try to guide them into, wearing obviously a collar and, keeping some stability and laying down on the back. And I always sort of say, buffer yourself because there will be bumps along the road. And that itself, is horrendous. And of course, when you have such severe, it's also important to recognize when you have such severe CCI and you've been bedbound for so long and you're a septad patient, there's so many other things going on with your body, right? So like there's the mast cell concern, there's the dysautonomia concern, there's the gastroparesis concern, there's, all kinds of other organ involvement concerns. So it's not just like, well, keep your neck stable and then just get across the country.
Yeah, and I don't want to leave the wrong impression here when I said index of suspicion CCI until proven otherwise. I think that, but I don't. I still start with looking for all the other septad issues. One, because it's clearly impacting their care, impacting their health, making their condition worse. What I'm saying is, I would think they're going to end up needing surgery, but I need to also work on these other issues. So
because the more stable we can get them, the better whatever travel they are able to accomplish will be for them.
Maybe another way to explain that is. In the bedbound patient, I'll do the septad workup and make attempts to treat it, but I'm not going to extend those attempts over a very long time.
Right.
Because it's clear to me that in those patients especially, medications are not going to fix the problem. The problem is now driving everything else. This is a question that comes up somewhere else, and it's a confusing question, but I think what we see often, not necessarily in bedbound patients, but in all these patients, is patient has, we'll just say they have septad issues. Okay, they have a septad presentation with dysautonomia and gastroparesis and SIBO, et cetera. And those conditions exist, and we work them up and we treat them. But at some point, if they develop CCI and or already have it with brainstem compression, that pathology becomes the new driver of the other issues of septad. It's a very sort of paradoxical thing. So in the bedbound patient, I think they're already at that point is what I'm trying to say. Yeah.
Right. And it is a little bit of when do you intervene, right? So sometimes we get patients who are already bedbound, and I always think, I wish I would have met you a year, 2, 3, 5 years ago. Sometimes we get patients who are not yet bedbound, and I work real fast trying to avoid that for them, right? And then we get a lot of patients who are sort of, on the mild side of the septad, not feeling well. It might be a long COVID patient, for example. So this is sort of fairly like new changes in their functionality and their health status and their physiology. And I always worry like how aggressive to be, right? Because I want to prevent what I know could potentially happen. And I think that's, sometimes I think that that's the downside of doing what we do, because I could see where this could potentially go, but we also know it doesn't always go that way, right? So I try very hard to sort of balance, like, I don't want to scare you, it could potentially go this bad, but it doesn't necessarily have to. I want to really work hard to sort of prevent all of this, but I don't want to be so aggressive and like throwing, polypharmacy at you either, which then of course there's added risk to, multiple medications, of course, not only the mast cell reactions from the medications themselves, but just the side effects of medications and toxicities of medications, so I think there's a lot of a balancing act that goes on for each and every patient. Like, I don't have this generalized approach. Like, it's literally for an individual patient, I sort of make decisions and tweak my plan for them based on their feedback and their response to what we're doing now.
Yeah, I think we're kind of in the midst of a tragic but very enlightening natural experiment. And again, there's a question that somebody asks about this. We're not seeing CCI in our long COVID patients yet. Yeah.
I am.
Well, I mean, but not to the degree.
Oh, yeah,
that
you're
we're
right.
seeing.
Not the
Okay.
bedbound.
And the
severe
operative word
type.
here is yet. Okay. And I think that's because their illness has had a much shorter duration.
Mm-hmm.
And I suspect that the ones that you see, the long COVID you see with CCI and that I see with CCI, when you take your first history, it's obvious in 15 minutes that they actually have hypermobility EDS. They have a lifelong history of mast cell. Maybe they have mono when they were a kid, and they were doing fine, fine in quotes, meaning they felt fine. But then they got the final kick with COVID, and that pushed them over the edge. And so they're further down the line, so to speak, in terms of connective tissue damage.
Correct.
But there's millions of people with long COVID who may not fit that history, but they will go on to get CCI, or may go on to get CCI if we are not able to intervene and reverse that whole septet picture that they're evolving. So it's a matter of time. I mean, you and I see patients in the ME/CFS septet world. Most of our patients have a history of 5 to 30 years. Long COVID is 3 years almost by definition. So in a sense, we have this painful opportunity to watch this disease evolve, and hopefully we'll have learned, and then the NIH will learn, and everybody else, from the experience that you and I and our other colleagues have had, so that we can try to prevent that progression. I'm not optimistic about that because everything seems to work so slowly at the government level, but I think it's a crucial concept that the world has to understand, and we have to try to get doctors to understand. These patients need to be addressed promptly.
Promptly is the key word, because we are in a window where we can make the most difference, is what I think.
Exactly.
So, and that's, I've gotten, I'm sure you have too, a lot of long COVID patients over the last couple of years.
Right.
And I basically see a lot of similarities, certainly in the ME/CFS world. I'm also seeing a lot of differences, right? I think there's a lot of distinctions to them. But I see connective tissue involvement regardless. And it makes sense to me, and I think connective tissue doesn't get the right respect it deserves, frankly, because the more I learn, the more I'm shocked that somehow we don't always look, we don't go right to the anatomy. We don't look more quickly. And I think it's because, medicine is sort of binary in many ways, and it's like surgeons and non-surgeons. And, if you're not a surgeon, you don't often think about the anatomy. And
Well,
I'm
it's
not a
also
surgeon.
organ system driven and taught medicine.
Right, that's
so
true. Medicine is
connective tissue is everything from
it's
toes
everything.
To top
I
of your
know.
head, so it gets lost.
It's true. And my husband, who, he is a pathologist, he was just telling me yesterday that he gets these aneurysms from these, they're not diagnosed as long COVID, but I look at them as long COVID because I'll say to him, do they have a history of COVID? And so if they do, I see it as a long COVID patient, but he gets these aneurysms as biopsies, and he does elastin stains. And so it looks at the elastic fibers of the vessels, which is connective tissue. And he says that he sees the difference, and I'm not saying this is different for long COVID patients than it is for non-long COVID patients, because aneurysms have been around before COVID, of course. So this is not, I'm certainly not saying this is in any way, specific for COVID. But he can see where the elastic fibers are wider apart than they are normally.
Yeah, but that could be a function or a caused by viral infection and viral reactivation.
That's
COVID
where I was
just
going
being
with
in the
this.
800-pound. Oh,
Right.
I'm sorry.
No, that's okay. No,
Yeah.
So that's the conversation that he and I had,
Right.
which is that, well, what virus? Of course, he doesn't know because the history is. It's not that it's not in the chart. That nobody takes the appropriate history. So who knows what these patients have been exposed to in the past, right? So another virus, another bacterium, another environmental exposure. There's lots of different things. I think that my point being is going back to the connective tissue, right? So he sees abnormalities in the connective tissue, which is what causes the aneurysm, which is this, loss of integrity, right? So it can't hold that vessel together. I do think there's a lot more vessel involvement in long COVID than there seems to be in ME/CFS. I think a lot of my patients are describing, blood flow abnormalities more so than I think the ME/CFS population does. Again, this is just like my own anecdotal, observational, empirical. I have no studies to prove any of this. This is just what I've been seeing and talking to patients. And so I'm just sort of curious about that. But of course, I don't know what ME/CFS, how it started. for a lot of the patients that I see, certainly, because I sort of admittedly came late to the game to ME/CFS than you and certainly several of the other clinicians we work with have come. And so maybe early on, this is what it looked like. There was a lot more vasculopathies than there are, at least in my patients now.
Well, and I think there's actually a real push to learn more and look more for that in the ME/CFS patients.
Yeah, it would.
I mean, this is a reverse. We've been talking about how physicians can learn from ME/CFS in order to treat long COVID, but the reverse is true as well. The recent work in long COVID by the South African group and the German group about blood clots and microclots and endothelial inflammation disease is clearly beginning to be looked at in ME/CFS and being found. So I do think it's probably there. I wanted to say something else on the elasting and the stuff that Steve is doing. That's the whole issue of the septet.
Right.
Okay. And it's, our friend Andy Maxwell is a pediatric cardiologist, and he has this leaky spiky theory. Spiky leaky.
Spiky.
Sorry,
spiky,
Andy, I can't remember which way it goes.
Leaky, spiky.
Anyhow, it's this amazing talk he does. And
achy, breaky.
And the key piece is how with mast cell degranulation, they release chemicals and molecules, and these can, for want of a better word, dissolve connective tissue. And, once doesn't do anything, 100 times maybe it doesn't do anything, but maybe the 5,000th time that you have system-wide activation and release, it starts to really give you ongoing cumulative permanent damage, and then you're kind of walking down the road here of this whole septet picture. And that's true for mast cell activation and degranulation. It's going to be true for SIBO and leaky gut. It's going to be true for chronic infections and reactivation. They're all doing it. There are papers that clearly demonstrate that Lyme disease can cause mast cell activation and connective tissue injury. So to just put it all together in a big pot, you can imagine what happens.
And that's what we see.
Exactly.
Right. So, and as you said, connective tissue is everywhere, right? Head to toe. And it holds things together, and it holds the cranial cervical joint together. In fact, that joint is held together by many different ligaments because nature had it so that that area was very protected because it houses just such important critical anatomy, such as the brainstem, such as the vessels that bring the blood and take the blood, and CSF compartments, and so much more. And then once you have instability, of course, everything is just moving, right? So everything is unstable and can move and then cause compression even further, right? Which we see with the jugular vein when we see compression from the C1 tubercle, or even from the styloids, which with connective tissue problems, there's overgrowth of certain ligaments that then pull on the bone, which then can create elongated styloids, and that can sometimes compress as well. So you're right. So, that critical part of our anatomy, which can have so many different symptoms and present in so many different ways, because it involves the lower cranial nerves, it involves the nuclei of the brainstem, it involves so much more anatomy, can present with so many other symptoms that ultimately makes it for where a patient just can't function and do any activities of daily living. And then they're just relegated basically to their bed.
Right.
And then, then there's a whole, of course, with the CSF leaks. And every time I hear a bedbound patient, I always have to make sure they don't have a CSF leak because they can't be upright. So why is that? That's always the low-hanging fruit, but that's also hard to prove. And, of course, to get them imaging, that's another, forget about travel to the neurosurgeons.
Just the imaging alone is
just to get them imaging is very, very difficult. And the imaging is not even reliable all that much. Right. And how many times do you get normal imaging back?
Yeah, no, that's why I go to traction right away.
Yeah. Yeah, that is definitely what we should all be doing, by the way, with bedbound patients.
Right.
Okay, so I think we went way off that question. I think we answered a lot more questions than that. Okay. So you make the point that CCI surgery is the only way to definitively fix instability, but I talked about that. How does that conflate instability with cranial settling? And I think we sort of mentioned that cranial settling is a little bit different from instability, though cranial settling can contribute to instability because there is compression from that hindbrain, which sort of comes down with cranial settling, and then it can push upon the joint, and so then can further cause instability for sure. Do patients have instability invariably have cranial settling? That's a really good question, actually. So not always.
Right. We were talking about that earlier.
Yeah.
Yeah, I think you can have instability without, just like you can have a lax joint, a loose joint without full dislocation or without requiring surgery right away.
Right.
I can painfully attest to that fact. So yeah, it's a spectrum.
It is a spectrum. For sure.
But, it comes up in a question there, but let me just jump in and bring it up now.
Yeah, go.
So one of the reasons that I prefer to work with Dr. Bolognese is his absolute unequivocal dependence and requirement of invasive cervical traction.
Mm-hmm.
And I just think that it's an annoying problem, an annoying requirement at times, but it is the best way to demonstrate before the scalpel hits the neck that patient is likely, 90+% likely to benefit from surgery. And it basically, that's how you determine or distinguish between the spectrum of CCI and the condition of cranial settling and brainstem compression. And it's a crucial difference, and no other surgeon does it. I don't know why nobody else is doing it. I do think there are moments when, for want of a better word, he misses patients who do need surgery because they didn't have a clear positive ICT. And those are very frustrating moments for the patient and for me if I'm the referring physician. But that is a small minority, and it doesn't in any way take away from the extraordinary value of that procedure.
Right, but I mean, it should be recognized, and we should acknowledge the risks that neurosurgeons in general and Dr. Bolognese takes with these fusions. And of course, it's still somewhat controversial,
Right.
still not widely accepted. So he has to, in some ways, he has to have criteria that, just to keep himself like safe, right? And if it hasn't met his own criteria and he still chooses to operate, and there's a poor outcome, of course that puts him at
I
great
respect
risk.
his decision. I'm
Yeah.
just saying that there are
It's
a few
frustrating.
patients who may have some other version, for want of a better term,
Right.
of CCI brainstem compression that just somehow is not showing up the right way.
Well, there is that component of horizontal versus
Right.
vertical instability, which sometimes is a confounding factor during the ICT. And so that can sometimes be the reason why it's not, remarkably positive. And sometimes, I've had patients who clinically, like crazy positive on ICT, just different people
me
under
too.
traction, but morphometrically, there aren't the kind of change in measurements that he likes to see.
Right.
And so he'll have them come back in 6 months, which
Right.
of course is still frustrating for the patient who's already been suffering usually for years, and frustrating for me because I've now forced them to go out to New York, with the hope of a
been there,
fusion.
several patients.
Yeah.
And usually in the ICT, for those of you who don't know about ICT, it's the procedure's two-pronged. First, it's he puts the halo on and does the traction, and there's the subjective piece of, is your brain fog better, is your vision better, is your pain better, is your headache better? And that's profoundly informative, and in most patients, it's very, very positive, meaning demonstrates CCI. It's the morphometrics that he's doing at the same time while this is happening that don't demonstrate enough of a change in the BDI and all these other measurements that he feels he doesn't have the details he needs to perform an operation.
Right.
And that's very frustrating because the patient will come back to me and say, I made this trip, I spent a lot of money, et cetera, et cetera. I crashed for 3 weeks after the trip.
Mm-hmm.
I was very positive subjectively, but he won't do it because I didn't get the right measurements. And
Right.
there's not much I can say.
Right. I mean, but you do warn them before they go that
of
this
course,
is
of
a
course.
possible outcome.
And some of those have gone back 6 months later. In fact, one of them was there last week when you were there, and she was positive, and they did the surgery.
Yeah, I really, I need to go back there more often. You should come with me
I wanna
next trip
come,
because, it's really interesting to actually talk to the patients who are post-operative, like immediately post-operative. Obviously, we talk to them post-operative all the time, but this is literally like the day after surgery or 2 days after surgery.
I'd love to. Actually, I keep wanting to be in surgery and see it too.
You can do that.
Yeah.
So we have 5 more minutes for this episode.
All right,
And there's still more
choose an easy question.
An easy question. There's an easy question. Is there an easy question here? Oh, yeah. This one you said was an easy question about does Lyme in the persister state cause symptoms, or is it only a problem because of the potential to switch back into the active replicating state?
You know why it's easy? Because I have no idea. So I don't think in the persister state theoretically that's causing disease or symptoms.
Right.
I think it's the opportunity for that bug to reactivate and cause, and that can happen cyclically or randomly or whatever. But in the persister state, I don't think so. Just like TB in the persister state or latent state for 50 years doesn't cause a problem until it reactivates. I think it's the same model.
Okay. I think that's a good one. How about Do IH patients have an increased risk of cerebral hemorrhage from taking blood thinners such as Plavix? So I'll answer
You're
this.
the neurologist. You answer.
The answer is no. I mean, so I think what's important to note is that there are volume compartments of the CNS, and one is the CSF fluid, one is the arterial system, one is the venous system. They are technically separate compartments, but there's an exchange. So there's dynamics between them for sure. But there's no increased risk of a spontaneous bleed from taking Plavix or any kind of blood thinners. I will say, though, that this triple anticoagulant therapy for long COVID sometimes scares me in general, and it's got nothing to do with IH or not, but because I do think that patients are being put at increased risk of
No, I
bleeding.
agree. I won't do it.
Yeah, I haven't done it for that reason.
Yeah.
Not that I haven't done an aspirin and or a Plavix at
Right.
some times, but the triple anticoagulant I haven't done. I've had a couple of patients who have bled on the triple anticoagulant, and it's because they had abnormal coagulation factor panels that no one had picked up on, and so that worries me about this whole idea of triple anticoagulant therapy, which is sort of off topic of this question, but made me think of it. But in general, IH patients, just because they have elevated intracranial pressure, they are not at increased risk of spontaneous bleed or cerebral hemorrhage from taking Plavix or aspirin for that matter. It is a purely CSF compartment concern, and while there's exchange with the blood compartments, there isn't any kind of connection. So in terms of coagulation and or risk of bleeding. So yes, no, that would be safe.
So I know we need to finish up, but I want to just make two more comments. So there is risks of spontaneous bleeding that appear to be spontaneous when you anticoagulate somebody with aspirin, Plavix, Coumadin, Lovenox, Eliquis, whatever, particularly from the GI tract. And so I always very carefully discuss that with a patient. A patient can have minimal gastritis from taking ibuprofen, and if they're on an anticoagulant, that can turn into a GI bleed. So it appears spontaneous. It is not spontaneous. And then the other point is something you and I mentioned before we started. My biggest concern with my non-bedbound patients is if they fall and hurt themselves, have trauma while on any of these anticoagulants, obviously, particularly the risk to the head. So that's a significant issue. And I have patients who still jog and things like that, and I'll go over that very carefully with them.
Yeah, no, so do I, absolutely. Yeah. I make sure that they are not doing anything where there's lots of contact, where they can really sustain any kind of physical injury, for sure. Okay. All right. Well, thank you for joining us on this episode of Unraveled: Understanding Complex Illness. We will see you again soon, and keep those questions and comments coming.
Thank you.
Bye.